So good afternoon, everyone. Welcome to Medical Grand Rounds. It's 12 noon, so we'll get started. Just a reminder to please leave your questions to the end and enter your questions in the chat. And please answer a brief survey that will be sent to you after the presentation. This will let us know that you were present today. Today's Grand Rounds are brought to us courtesy of the Division of Hematology. And I will ask the Chief of Hematology, Dr. Chantal Séguin, to please introduce our guest speaker today. Thank you, Chantal. The floor is yours.
Thank you very much, Dr. Giannetti. It has been, I think I've heard a few times that we have tried to have Dr. Sholzberg present to us in the past, and I'm very, very happy that she has accepted and she was available this year to present. So I'm going to just introduce, it's a pleasure to introduce Dr. Sholzberg. Dr. Michelle Sholzberg received her medical and residency training in internal medicine at McGill University. She also completed additional postgraduate training in hematology at the University of Toronto and a research hemostasis fellowship in Toronto and internationally. Dr. Sholzberg has a Master of Science from the University of Toronto in clinical epidemiology and healthcare research, and was awarded the Claire Bombardier Award for Career Promise as a Scientist. She is a clinician-scientist with a focus on coagulation. She's the Division Head of Hematology-Oncology and the Medical Director of the Coagulation Laboratory at St. Michael's Hospital. She is also the Director of Hematology-Oncology Clinical Research Group and co-director of the Hematology-Immunology Translational Research Theme of the Shing Knowledge Institute. Also, Dr. Sholzberg is the Associate Editor for Illustrated Materials at Research and Practice in Thrombosis and Haemostasis. She is currently involved in many different projects, studies. Some of them are prediction tools for perioperative and traumatic bleeding, as well as the intersection of women's health and bleeding disorders, treatment for iron deficiency anemia, as well as new treatment for immune thrombocytopenia and the management of COVID-19 coagulopathy. Dr. Sholzberg has received multiple awards and has numerous publications on the topic of hemostasis and benign hematology disorders. It is a pleasure to have her today talk to us about women with bleeding disorders, and I leave the presentation to start and the lead for Dr. Sholzberg.
Thank you very much, Dr. Séguin. Thank you, Dr. Giannetti. It's a real pleasure to be here, especially to present at the MUHC Grand Rounds. The MUHC will always feel like my home. And I noticed some of the people who've logged on and many, many familiar names. I wish I could see you all in person. So today I'm going to speak about women and bleeding disorders. I will focus on von Willebrand disease as it is the most common bleeding disorder, and also talk about iron deficiency as an unfortunate example and model of structural sexism in medicine. So here are my relevant financial disclosures, but most importantly, I have a lot of intellectual bias in that my clinical and research focus is on coagulation in women's health. Here are some important disclaimers. So throughout the talk, I will use the terms women and woman and mothers to highlight the experience and care gaps of women with VWD and other bleeding disorders, and the term females in reference to the biological capacity to menstruate, become pregnant, give birth, and lactate. Of course, these terms are exclusive, and I ask you please to recognize that these experiences may apply to all people with the anatomy that allows for these things. That includes girls, transgender men, and gender non-binary individuals. So today we're going to go through the diagnosis of von Willebrand disease and its bleeding management in both the pregnant and non-pregnant patient, discuss barriers to care, and review the multifaceted impact of iron deficiency and discuss some approaches to its care. And then I will also review some new constructive directions. So VWD. So von Willebrand disease is the most common bleeding disorder. So up to 36,000 Canadians are affected with von Willebrand disease. And this is compared to about 4,000 Canadians that are affected with both hemophilia A and B in Canada. So if you're going to encounter a patient with a bleeding disorder, this is the patient that you're going to meet. And so hemostasis is a complex interplay of a bunch of very complicated steps that lead us to build a blood clot. And that blood clot stops us from bleeding excessively and losing blood, and thus losing iron. And so coagulation should never occur without trauma to the endothelium. And so whenever I teach about hemostasis, I talk about building a blood clot or a healthy blood clot like you're building a house. And so you're never going to build a house or a blood clot on pristine endothelial lining or the pristine green grass. First, you need to have the exposure of what's beneath the endothelium, which in our bodies is subendothelial collagen. And so when the intravascular space becomes exposed to collagen or the dirt beneath the grass, the blood goes berserk and realizes that it has to become activated to generate the formation of a hemostatic plug. And the platelets are first to go nuts. They are constantly searching for holes to plug. They flip their membrane inside and out to expose the negative charge. And they start looking for things to grab hold of. They can grab hold of collagen directly, but they also have other receptors that are looking for von Willebrand factor. Now, von Willebrand factor was named after a Finnish physician, Dr. Erik von Willebrand, who was the first to diagnose a family of individuals in the Foglo Islands with a very severe bleeding disorder. And at first, he termed this disorder pseudohemophilia. The index case was a young girl named Hjordis, and Hjordis died at her 4th menstrual period. And this family ultimately was found to have type 3 von Willebrand disease, which is the most severe form of von Willebrand disease. And so now here we have this large glycoprotein named von Willebrand factor. And this large glycoprotein that then further multimerizes to become an even larger structure is the glue, and it anchors itself on one end to subendothelial collagen, and it unravels itself to expose another arm to grab hold of platelets, and it starts pulling in these platelets to build the primary hemostatic plug or the platelet-rich plug. And that is the scaffold upon which you are going to start to further build your house. So then a series of coagulation factors are going to become activated, and fundamentally fibrin is going to be formed. Fibrin is like cement. So it's being poured into that platelet-rich plug. And now we're really getting somewhere. We're starting to build a real house, but it's not done yet. We have to stabilize the clot. We have to strengthen the house. And we're going to drop cross beams into the wet cement. And that's like factor 13 in our body to strengthen the clot. And then we're going to put walls and a roof in our house. That's akin to something called thrombin activatable fibrinolysis inhibitor, or TAFI. And essentially what that does is it covers up and coats the lysine residues, which is on the surface of the fibrin-rich clot, to hide it from the wrecking ball, which is plasmin. So a very complex interplay. Now, I've indicated that the platelets flip their membrane inside and out to expose their negative charge, to expose the phospholipids. And so hemostasis will not proceed forward without the exposure of this negative charge. And all of this was based on the scientific findings of Drs. Hoffman and Monroe in the late 1990s, early 2000s. And they coined this the cellular-based model of hemostasis. So clotting does not occur randomly in a vat of blood. It occurs in a very coordinated way on the surface of cells. So to give you more information about von Willebrand factor, to the left, this is an image courtesy of Dr. Paula James. This is an endothelial cell. And this endothelial cell is chock full of these green granules. The green granules are von Willebrand factor. So endothelial cells are just chock full of these bombs of the glue that is then going to get released when the endothelial cells become damaged. And so von Willebrand factor, unlike many of our other clotting factors, are not synthesized by the liver. Instead, they're synthesized by endothelial cells and megakaryocytes. And respectively, then they're stored in these 2 different granules within those cells, the Weber-Palade bodies and endothelial cells, and in alpha granules and platelets. And von Willebrand factor is this large, complex glycoprotein with multiple things that it can bind to. And as such, it has multiple functions, which means that it's complicated. And so making the diagnosis is tricky. And it's because it has both a role in primary hemostasis that I've already discussed. It's involved in the formation of the platelet plug. So it grabs hold of the platelets and anchors to subendothelial collagen, but it also binds to and shelters factor VIII. And in doing so, it substantially extends its half-life. So von Willebrand disease therefore straddles these two areas of hemostasis, both primary hemostasis and secondary hemostasis. And so what are the tests that we generally have available to us to evaluate hemostasis in patients? Well, really, unfortunately, many clinicians over-rely on the PT or the INR and the PTT. The end result of these two tests is the formation of the fibrin-rich clot, period. It looks very simply, therefore, at how long it takes the cement to form. With blinders on to primary hemostasis, doesn't even address the endothelium, of course, none of our assays do, by the way, and doesn't look at clot stabilization or fibrinolysis. It just looks at that one area, which is the formation of the fibrin, which is the cement. And so I've emphasized the importance of the cellular-based model of hemostasis in vivo and how hemostasis occurs on the surface of cells. Now, when we draw a sample for the PT-PTT, we draw it within a blue top tube, and that blue top tube contains sodium citrate. And with the PT-PTT, we are going to measure the time to fibrin clot formation in the test tube in the presence of their respective reagents. So the reagents are different for the PT and the PTT. But before we analyze the sample, the first thing that we do is we take the sample and we spin it down. We centrifuge it extra fast and extra long. And so the cellular pellet, which includes the platelets, the white cells, the red cells, fall to the bottom, and the platelet pore plasma floats to the top. That's the supernatant. Sodium citrate is important because you don't want the blood clot to form in the sample before you get it to the lab. Otherwise, your reaction's already occurred. You have nothing to measure. And so we are therefore using this platelet pore plasma as the in vitro representation of your patient's hemostatic capacity. But note that before we even put the sample on the analyzer, we've snubbed our nose at Hoffman and Monroe. And so there's a mechanistic disconnect between in vivo and in vitro hemostasis before we even put the sample on the analyzer, because there are no cells, or very little, in that plasma. So what's the origin of the PT-PTT? So again, the PT is effective at determining the amount of warfarin that is present in a sample at steady state, period. Period. The PTT historically was designed to screen for inherited hemophilia preoperatively in high-risk patients. What I mean by high-risk patients are family members of individuals known to be affected by hemophilia. So it's very, very different when you are screening patients who have a family history of hemophilia, so one brother and you're testing the other brother before they go for tonsillectomy, than doing a PT-PTT on every single patient preoperatively. These tests were never designed nor validated to screen for hemostatic defects in unselected patients. This is really important. Now, despite all of this, the fact that the PT-PTT doesn't even address the most common bleeding disorder, which is von Willebrand disease, and just looks very narrowly at this one area, and the fact that we know that the sensitivities of these tests in ruling out bleeding disorders is about 1% to 2%, these tests are ubiquitous and considered routine in many patient settings, including preoperative testing of patients. And the most sensitive test for a bleeding disorder is the clinical history. And so to that end, validated questionnaires called bleeding assessment tools, or VATS, have been shown to be effective screening tests. So the bleeding history is the most important test, but getting the history is complicated. And so that's why these questionnaires were developed, to standardize the ascertainment of the bleeding history. And they've been shown to improve post-test probability, and it substantiates the need for additional laboratory investigation. It can facilitate also exploration and variability in bleeding severity. It can even inform treatment decisions if your patient has a very high score, and allows for effective communication, because by conveying one number, I can describe how intense or not intense somebody's bleeding history is. And so here's an example of one of these validated questionnaires. This is the condensed MCMDM1 questionnaire, and it goes through all of these different bleeding categories. And a patient will accrue more points when they require more medical or surgical therapy to manage bleeding. And then you add up all the points at the end, and it gives you a sense of whether or not you should test the patient. And so for von Willebrand disease, the negative predictive value of a negative score on this questionnaire is 1. So the sensitivity is approaching 100% or 4. And the beauty of these BATs is that it has the ability to evaluate the entirety of hemostasis. We're not just looking at the cement formation or the fibrin-rich clot formation. We're looking at everything. We're considering everything. And so now getting back to the diagnosis of von Willebrand disease, I've already said it's a very complex glycoprotein, and patients shouldn't even be considered for the diagnosis of any bleeding disorder in the absence of bleeding symptoms. So I would suggest that you use a BAT to help evaluate the bleeding system and evaluate for any significant history. You're also going to ask about a patient's family history of excessive bleeding, but acknowledging that there's variable penetrance and expressivity of VWD, and thus a negative family history doesn't necessarily mean that your patient doesn't have VWD. And then, of course, there are laboratory tests that need to be conducted to evaluate for the presence of VWD. Now, the most common bleeding symptoms in patients with VWD is heavy menstrual bleeding and postpartum hemorrhage. So what are the lab tests? So the CBC, the INR, and the PTT should be normal. In fact, the PTT is almost always normal, even though I've said that the half-life of factor VIII can be diminished in patients with von Willebrand disease. Most of the time, it's not below the threshold at which point the PTT will become prolonged. So these tests are almost always normal. The most common finding, in fact, is iron deficiency anemia. And so there are 3 letters in VWD, 3 general aspects to consider: personal history of bleeding, family history of bleeding, laboratory test results, and 3 screening tests that should be done. And that's the VWF antigen, which asks the question, how much von Willebrand factor is present in the patient's plasma? Number 2, the VWF ristocetin cofactor activity or non-ristocetin activity-based assay, which asks how well does VWF bind to the platelet receptor? So it's asking how well does it do its job in terms of platelet adhesion. And we also evaluate factor VIII activity. So we're indirectly evaluating how well VWF binds to and shelters factor VIII, because if it doesn't do this job very well, then factor VIII can't accumulate and the factor VIII level will be lower. And so if these are decreased, it suggests the possibility of a bleeding disorder. And then, of course, there are more specialized tests that can be done. I'm not going to talk about them today. So the laboratory diagnosis of VWD is complicated, and obtaining a bleeding history is also challenging. And so if we look at the tests that we order in these patients, it often requires repeated measurement of both VWF quantity and activity relating to all of those different functions that I've alluded to. And you often have to test the patient repeatedly because there are a lot of variables that can affect the test results that you obtain. Both pre-analytical variables, just the way that you handle the sample, can result in false negatives or false positives. And also physiological variation can impact the results that you will obtain, meaning that we are rigged evolutionarily to be able to increase our von Willebrand factor and factor VIII activity in the face of stress, and also in response to increasing estrogen levels. And so over the course of a woman's pregnancy, her VWF and factor VIII levels should progressively increase, and this is to protect her from excessive bleeding at childbirth. Similarly, when our sympathetic nervous system is triggered and we're running for our lives, that relates back to pathways that were developed when we were hunters and gatherers to protect us from a potential fatal bleed. And so we're rigged in a way that with stress to increase VWF and factor VIII levels. So it's important to test your patient repeatedly. Now, these are just the general nuts and bolts of VWD classification. There's type 1, type 2, type 3 VWD. Type 1 is the most common, which is a mild or moderate quantitative deficiency. Type 2 is qualitative, and type 3 is the complete absence of VWF. This is what the patient Hjortis and her family suffered from. So again, VWD, 3 letters, 3 general considerations: personal history, family history, lab tests, 3 screening lab tests, 3 types. I'm not going to talk about the subtypes of type 2 today. But this is a more modern approach to VWD. And these are the international guidelines that were published not too long ago. And you see here that it becomes a lot trickier. And so here, the general gist that I would like you to remember is that if your VWF activity or factor 8 or factor 8 are less than 50% in a patient with a positive bleeding history, then you can consider the diagnosis of VWD. You should never be considering the diagnosis of VWD in a patient without a bleeding history or family history. How do we treat patients? Well, here are the general principles. We use a drug called VD-AVP or desmopressin. Antifibrinolytic agents such as tranexamic acid should be your best friend for these patients and many others. And then transfusion-based therapies, which includes VWF-containing concentrates. In Canada, those are Hum8P or Will8, and platelet transfusions because the alpha granules contain VWF. So what is VD-AVP or desmopressin? So it's a synthetic form of vasopressin. And it causes release of VWF from endothelial cells. It's a stress surrogate. And by releasing VWF, it also increases factor 8 because VWF and factor 8 are always linked. They always go together. So now let's talk about bleeding risk management at birth and postpartum. And along the way, I'm going to emphasize knowledge and care gaps for these patients. So as I've said, VWF and factor 8 levels increase over the course of a woman's pregnancy. And it's important, therefore, to test levels in third trimester to see if your patient has quote unquote auto-corrected or not. So if you have a patient with type 1 VWD, most of these patients will correct, meaning that because of this increase in estrogen that occurs over the course of her pregnancy, her VWF and factor 8 levels will often rise into the normal range, allowing for her to give birth with minimal hemostatic risk. And so that's great for the first few days, sometimes even the first week or so postpartum. But within hours to days, and it's different for each patient, the VWF and factor 8 levels will start to fall. And therefore, once the patient is discharged home, that's when the risk of postpartum hemorrhage or secondary postpartum hemorrhage is highest. And so it's really important to inform patients with regards to what they should or should not watch for with regards to their vaginal blood loss in the postpartum period. And anyone who manages patients in this setting or anyone who's been pregnant and given birth before will agree that this is a very blurry phase of life for a woman where you often don't remember what you've done, how much you're bleeding, and you're focused on getting some sleep and taking care of your baby. So there's a lot of reasons to be concerned about patients once they get home. And we know that there's a disproportionate risk of postpartum hemorrhage among these patients. So in the general population, about 6% of all deliveries are complicated by PPH, accounting for maternal mortality in high-income countries, about 13 per 100,000 deliveries. There are some estimates in the literature looking at various bleeding disorders. These estimates are flawed for many reasons, and there are methodologic problems with a lot of these studies that have been conducted. But fundamentally, the risk of postpartum hemorrhage is much higher in patients with bleeding disorder, as is the risk of maternal death. And so what are the treatment options for patients? So those who do not optimally correct their levels physiologically over the course of their pregnancy, these are the patients that require additional treatment. And here you're going to think about the provision of VD-AVP, VWF factor containing concentrates, or platelet transfusions for very complex cases. And it's important to acknowledge that for these patients, you're thinking about mother, you're thinking about baby because it's an inherited disorder potentially, and you're thinking about the risk of bleeding at the time of delivery, postpartum, and you're also thinking about, can you safely provide neuraxial anesthesia? I feel very strongly from an equity perspective that every patient who can safely obtain neuraxial anesthesia should be offered it. And thus, I will treat patients solely for the purpose of allowing them to have proper pain control. So what levels are we targeting to decrease the bleeding risk around labor and delivery in these patients? The truth is, we don't know. There's really poor evidence in this area. We do not know. Some people say above 50% is what we should be targeting. Others say 100%, others say greater than 150%. The truth is, in patients without VWD, generally levels of VWF activity are going to rise well above 250% in the third trimester of pregnancy. So even though these patients, quote unquote, autocorrect, meaning their levels will go above 50% towards the end of their pregnancy, is that true autocorrection? Are they achieving true physiological variables? And the truth is, we don't think so. And so likely patients have been undertreated for many, many decades. So it's really important to personalize care and to consider all aspects of their obstetrical care when you're making these decisions. Tranexamic acid. Based on the findings of the woman trial, tranexamic acid should be used very liberally in the obstetrical population in those who are experiencing postpartum hemorrhage. I use tranexamic acid prophylactically in this patient population, even if they have fully autocorrected by the time of delivery. So they receive a dose of intravenous tranexamic acid on call to the OR should they be having a C-section or at the second stage of labor, i.e. when they're pushing. And everyone also will get oral tranexamic acid to take home with them. And it's excreted in less than 1%, at less than 1% in breast milk. I know that this may make some care providers feel very nervous because people often worry about the provision of tranexamic acid and the risk of thrombosis. We have studied this formally in 38 patients and presented on this. All of the patients who received tranexamic acid in the postpartum setting did not experience a PPH, and none of those experienced a thrombotic event. We have since completed a review of now well above 100 patients. Again, no increased risk of thrombosis was found in these patients whatsoever, which is akin to the experience with tranexamic acid in the general patient population, including those at high risk of thrombosis. And so we believe so strongly in the use of tranexamic acid postpartum that we have education materials for our patients to teach them how to take it properly. This is also supported by the recent guidelines of VWD suggesting the use of tranexamic acid. But again, this is all based on very limited data. What about neuraxial anesthesia? So generally, we say epidural anesthesia can be safely performed when factor concentrations are in the normal range if there are no other contraindications. But it's really hard as a clinician to operationalize that. And so a wonderful trainee working with me, Dr. Wynn Peterson, is doing a large study evaluating what are the appropriate thresholds to allow for safe neuraxial anesthesia. She conducted a scoping review that we published that basically said, we have no idea. We were unable to generate any conclusions other than to say that more research is needed because we have no idea based on the existing literature what to do. As such, the guidelines suggest that neuraxial anesthesia can be provided when levels are above 50%, certainly above 100%, and most certainly above 150%. But again, based on super low certainty of the evidence. We are therefore conducting a modified Delphi study with experts from anesthesia and hemostasis internationally, and it's endorsed by the ISTH, and those results will be coming very soon. But the bottom line is, we don't know, and a proper study needs to be conducted. So now that I've talked about obstetrical considerations for patients with VWD and highlighted some knowledge gaps, I'd now like to shift our gaze to the non-pregnant patient with VWD and discuss the impact on overall health and well-being. So gynae and OB complications in patients with VWD are really common. And it's described as over 95% of women with VWD have heavy menstrual bleeding, so it's essentially universal. And as I've discussed, there's an increased risk of postpartum hemorrhage. There's also increased risk of bleeding after miscarriage, during pregnancy, and potentially an increased risk of miscarriage in general amongst patients with bleeding disorders. But this is currently unknown as well. There is a higher cumulative incidence of heavy menstrual bleeding and hysterectomy in women with VWD compared to those without VWD. So on the left, we're looking at heavy menstrual bleeding. The green line is patients with VWD and the gray is without. And to the right, we're looking at hysterectomy. Health-related quality of life scores are lower in patients with VWD than in the general population, and it seems that those with severe bleeding symptoms and women by the impact of heavy menstrual bleeding are disproportionately negatively impacted. In particular, teenage girls have a lower health-related quality of life compared to those that are unaffected, especially in school functioning and psychosocial health domains. And this is thought to be due to the impacts of heavy menstrual bleeding, dysmenorrhea, anemia, and anxiety. And a lot of the anxiety is triggered by the concern of soaking through one's clothes, which obviously could be a traumatizing experience for a young girl at school. And just to give you a sense of, what type of negative health-related quality of life are we talking about here? So their scores are akin to an HIV-positive man with severe hemophilia. So now I'm going to talk about the lived experiences in patients with VWD and other bleeding disorders. And this was led by a wonderful trainee who's now a transfusion medicine fellow, Dr. Sumeda Arya. She interviewed 15 women. It was a qualitative study where we evaluated transcripts for using thematic analyses. And then we pulled out the common themes. The median age of the individuals that were interviewed was 31 years old, and here were the diagnoses that were included. And this was because there was a dearth of literature surrounding the lived experiences in these women. And so here were the main themes that emerged. So there was a negative impact on daily life and identity. There were uncertainties surrounding diagnoses. There was a conceptualization of experience through a family history of bleeding and through an intensity of bleeding symptoms. And so I'm just going to read out a couple of quotes here and there. So here's one: when I started my period, I wasn't sure what was normal or not. So it's difficult for the patient herself to identify normal versus abnormal bleeding, which is problematic, which implies that she will not likely present, especially if her family members are also bleeding heavily. This other study, led by Dr. Heather Vandermeulen, who's also a transfusion medicine fellow, looked at the experience of postpartum bleeding in women with inherited bleeding disorders, because we wanted to know if women with inherited bleeding disorders can even identify postpartum vaginal blood loss when it's excessive, and are we effectively managing them? And so here are the themes that emerged there: that there was missing dialogue surrounding vaginal blood loss, lack of effective communication around postpartum bleeding, intensive normalization of bleeding with a skewed frame of reference regarding vaginal blood loss. There was also key themes surrounding inadequate access to care and geographical and socioeconomic barriers leading to diminished access to care, and lack of preparation and lack of communication amongst clinicians. And so here's a quote from there: I didn't have to call an ambulance. I wasn't in and out of consciousness. Those are my opinions of true hemorrhages, but it wasn't like that with my delivery. So again, talking about a skewed frame of reference. So this normalization and desensitization are really important concepts to acknowledge in women with bleeding disorders, because we know that up to 95% of these patients with VWD experience heavy menstrual bleeding, but only 70% of them or actually 70% of them will report normal menstrual bleeding, even if they have measurements that are in keeping with heavy menstrual bleeding. So again, they're completely desensitized to what excessive vaginal bleeding is, and they will gauge the normalcy of their experiences by referencing family and past personal experiences. So if they've had catastrophic bleeding in the past and they have ongoing heavy menstrual bleeding, they're very likely to downplay it. And I see this every single day in my clinic. And when those referenced also have abnormal bleeding and heavy vaginal bleeding is normalized, that leads to not only desensitization in the individual, but there are generations that become desensitized. And so we're only passing down this torch of normalization of vaginal blood loss. Moreover, there's such stigma surrounding discussion of vaginal blood loss that this further obstructs conversations with non-relatives. So a lack of opportunity to even begin to gauge what's normal versus not, because women just don't talk about their periods. And so Dr. Arya also looked at barriers to care in that same patient population. And here are the themes that emerged there. So healthcare provider dismissal of symptoms, limited access to care and treatment plans, need for self-awareness and advocacy, and lack of healthcare provider awareness of inherited bleeding disorders. And here's part of a quote: "You have to be prepared to advocate because you can't rely on them to know what you're talking about." So again, this brings us back to the diagnosis of VWD. So as you can see, if our patients can't even gauge what's normal or not, and if care providers have difficulty gauging what's normal or not, or dismiss patients, that this can cause a huge problem. And so there's a problem with considering this very first element of just making the diagnosis, which is why patients are experiencing substantial diagnostic delays. So it's the most prevalent inherited bleeding disorder, but we are not diagnosing it early enough. And the average time from first symptom to clinical recognition is 16 years, which is on average 6 years longer for women versus men. And again, the key barriers that were identified is this under recognition of heavy menstrual bleeding as being associated with VWD, challenging differentiating normal versus abnormal bleeding symptoms, because unlike men with hemophilia, women cannot be bleed-free in their reproductive years. There's a lack of timely specialist referral, and there's lack of access to coagulation testing. And so this leads to serial misrecognition and dismissal. And that's really a shame, because even if a patient acknowledges and recognizes that her bleeding is abnormal and she presents to medical attention, she is still experiencing dismissal, which leads to serial misrecognition, which leads to delayed diagnosis, which leads to lack of opportunity for treatment and lower health-related quality of life. So as I've said, the bleeding history is the most important test of hemostasis. And great, we have these BATs, but are physicians being adherent to the use of BATs? And there's this assumption as well that we are somehow experts and that we know how to effectively ask about menstrual bleeding and what's normal versus abnormal. But is this even true? So one thing that I've noticed repeatedly is that clinicians often ask, do you have heavy menstrual bleeding? And so if we're leading with that question, we're encouraging the patient to lead with her own bias. If she's bled heavily her whole life, she's going to say, no, it's normal. So if you don't dig deeper, the conversation is over. And so we know that heavy menstrual bleeding is defined as a menstrual blood loss of greater than or equal to 80 milliliters per period. But how do you even begin to operationalize that? I have no idea. And so the VWD guideline panel proposed the following definition for heavy menstrual bleeding to enhance care and research. So a period lasting more than 8 days, having to soak through one or more pad or tampon every 2 hours, having to double up with a pad or tampon at any one time, changing pads or tampons at night, repeated passage of blood clots, needing to sit on the toilet because you're passing blood clots, and then a PBAC score of greater than 100, which I will explain here. So there are these historical tools to help us quantify vaginal bleeding, but they're just not practical. So there's the alkaline hematin method. Nobody uses it anymore. There's the PBAC, where you will ask a patient to quantify her blood loss using these images. So to basically describe how soaked or not her pad or tampon is. But just very recently, this was published in 2021, Dr. Paula James conducted a study using modern sanitary products. So we have just gotten around to updating the PBAC using modern products, because the historical PBAC that everyone references was conducted in the 80s. So there are so many knowledge gaps and deficits, and a lack of comfort between patients and clinicians around the discussion of vaginal blood loss. We make an assumption that clinicians and trainees can confidently ask about vaginal bleeding. But we have no idea if trainees or even if established clinicians feel comfortable discussing vaginal bleeding or appreciating what's normal versus abnormal. And so Dr. Fartoon Siad, who's working with me, has conducted a study speaking to 73 medical trainees, determining how comfortable or not they are in obtaining a vaginal blood loss history. And I'll just give you the highlights here. And so here are the general feelings and comfort levels. So ranging from red, strongly disagree, to green, strongly agree. So surprisingly, many felt pretty comfortable talking about vaginal blood loss, and also in their ability to diagnose primary postpartum hemorrhage, but less of those felt comfortable diagnosing secondary postpartum hemorrhage, i.e. after 24 hours post-delivery. But this is what's really interesting, is when we ask the trainees if they're aware of the following tools: the PBAC, the alkaline hematin method, bleeding assessment tools, or menstrual cups, they said, well, very few knew what the alkaline hematin method is. Very fair. 20-something%, the PBAC, they'd heard of it, and about 50% heard about something like the Diva Cup or these BATs, these bleeding questionnaires. But when we asked them if they use them in clinical practice, nobody's using the BATs. And as we said, the BATs are critical now to help facilitate exploration of the bleeding history, especially vaginal bleeding. And so there are many examples in medicine of structural sexism, and I'm going to wrap up with a discussion of iron deficiency as an example of structural sexism in medicine. So as we said, essentially everybody with VWD has heavy menstrual bleeding, but even in patients without bleeding disorders, 61% of them, up to 61% of them, have heavy menstrual bleeding. So this is a really big problem. And especially since heavy menstrual bleeding is almost always associated with iron deficiency plus or minus anemia. And if you don't slow the bleeding, you will not solve the iron deficiency, and you will not improve health-related quality of life. Why do we care about iron deficiency? Of course, there are important consequences, including significant anemia, which is an indicator of end organ damage and risk of blood transfusions. And of course, we never want to give a woman of reproductive age a blood transfusion if we can avoid it, but also because there are really important symptoms associated with iron deficiency, even in the absence of anemia. And this has been shown repeatedly. And so patients, of course, are weak, are fatigued, but they also have worse attention, memory, and speed, which is shown to decrease IQ. It affects run times and exercise tolerance in general, and is associated with mood disorders, including postpartum depression. And all of this translates into decreased health-related quality of life, even in patients without anemia. Most importantly, if you treat it, all of that negative stuff goes away. Now, the global prevalence of iron deficiency anemia, not just iron deficiency anemia, is estimated to affect about a third of the world's population and is one of the leading causes of disability worldwide, and disproportionately affects women. Now, I'd like to emphasize that this is a gross underestimate of how many individuals worldwide are in fact affected. And so iron deficiency is the original pandemic. Here are the WHO guidelines that suggest the ferritin reference intervals to make the diagnosis of iron deficiency. So this is just one example of how underdiagnosed iron deficiency is. And this is because it is well known that a threshold of 30 is associated with iron deficiency when you reference it to the gold standard, which is a bone marrow biopsy. And so we are underdiagnosing iron deficiency, therefore under-treating iron deficiency. And we conducted a systematic review to look at the origin of ferritin reference intervals, acknowledging that less than 30 is generally accepted as an appropriate threshold. We evaluated 62 studies. And overall, we found that these studies were of very low quality at very high risk of bias, and mostly because these studies included apparently healthy individuals, but they didn't even assess for clinical history or lab tests for iron deficiency or its risk factors. And of the most 5 commonly used commercial ferritin assays globally, none of them excluded patients with iron deficiency risk factors, nor even adhered to CLSI reference interval and establishment guidelines. And that's a big problem. And so if we look at the literature review, like the systematic review in general, and we define the median for females versus males, you'll see that females have a lower limit of normal. And this is true as well for the commercial labs. And so really many individuals, including myself, suggest adopting evidence-based clinical decision limits to help clinicians identify and treat iron deficiency so that you decrease the risk of propagating this iron deficiency related health inequity, as it's an example of medico-social injustice. What about the diagnosis of anemia? So I think it's really important for us to look at things that are accepted as dogmatic truths in medicine. Is there good evidence to suggest that there should be sex-based thresholds for the diagnosis of anemia? And is there good evidence to suggest that there should be pregnancy trimester-specific thresholds for anemia? The idea here is that the differences are entirely physiologic and have nothing to do with pathophysiology. It's important to look at that and question that. And so hemoglobin thresholds, according to biological sex, are equivalent until menarche. And that's where it diverges. Now, these thresholds were first defined by the WHO in the late 1960s, and that was on the basis of 4 published references and 1 set of unpublished observations, only 2 of which, in fact, even address sex-related differences. And all of these were conducted in apparently healthy individuals, none of which inquired about dietary habits, iron supplementation, risk factors for iron deficiency, nor symptoms of anemia. So we are essentially sampling patients who may have iron deficiency themselves to define the normal ranges for hemoglobin and for ferritin. Moreover, there is heterogeneity amongst guidelines suggesting how to appropriately manage women with heavy menstrual bleeding and iron deficiency anemia. So there's a strong need for harmonized guidelines across all aspects of the management of heavy menstrual bleeding, including the management of iron deficiency anemia. And now, of course, I'm very much focused on structural sexism in this talk. I haven't even scratched the surface with regards to other examples of structural discrimination. And so iron deficiency also disproportionately affects individuals of minority race and ethnicity, those of lower socioeconomic status as well. So there's a mismatch between those who are tested and those who are treated for iron deficiency anemia and those who need it. It's also an intersectional storm. So it is the most common micronutrient deficiency globally. It affects 2 billion people annually, and it is the most common cause of anemia. It disproportionately affects women of reproductive age during our most productive years in life, and is the leading cause of years lived with disability in women worldwide. But it's not often discussed. And so there is a cycle of sexism in bleeding disorder management. And so only 4 out of 10 women experiencing heavy menstrual bleeding will seek care for it for all of the reasons that I described earlier. VWD is far more common than hemophilia, but it has significantly fewer resources devoted to it. Lack of knowledge and comfort amongst healthcare providers in discussing vaginal bleeding is a major contributor. And we are breaching some of the principles of bleeding disorder management in the way that we approach patients with VWD. So the basic tenets of bleeding disorder management are treat first when a patient presents with bleeding and investigate them later. But we have to remember that that's if you believe the patient and if they have access to care, which includes diagnostic testing and treatment. So despite the high prevalence of VWD, the near universality of heavy menstrual bleeding and iron deficiency, the role of VWF replacement for prophylaxis in heavy menstrual bleeding is as of yet undetermined in VWD. And in the near future, we will be conducting a clinical trial to assess this. So it's remarkable that this has not been assessed to date. And a patient with VWD has to earn prophylaxis in a way that a male patient with hemophilia does not. And this is evident when you look at the guidelines side by side. So what are some constructive new directions? There's lots of a need for education for self and also others, and also health-related advocacy efforts. And these are shown to be protective, and we found this in our qualitative work. There are many examples of good work that is being done, but it's important to acknowledge that it's unfortunate to shoulder people who are unwell with excessive responsibility. It's our responsibility to help advocate and educate. Also, another theme that emerged in our access to care work is that a lot of patients feel empowered through community affiliation, and this is particularly true for adolescent girls. And so I'm very grateful that there are a bunch of wonderful patient advocacy groups that provide tremendous support to patients, which provides empowerment, enablement, and a sense of acceptance. And so additionally, in our qualitative work, it was found that having a multidisciplinary care plan for labor and delivery was protective And so at St. Michael's Hospital, we put together a very clear multidisciplinary care plan that describes the diagnosis, that provides care for the mother, for the baby, with anesthesia and obstetrical and pediatric hematological recommendations. And we've shown that these care plans are useful and make patients feel more safe and comfortable. And the same is true for the healthcare providers that had access to them. Another area that we are focusing on heavily in Ontario is we're focusing on raising the bar. And we are going to make a shift imminently at the 3 largest commercial laboratories in Ontario, so Life Labs, Dynacare, and Alpha Labs, and many hospitals within Ontario, to adjust the lower limit of normal of ferritin to 30 in adults and 20 in pediatrics. So we're moving to clinical decision limits and attaching it to a knowledge translation and exchange program in the form of a website. So I'm grateful for a lot of things. I do not intend for this talk to come off as nihilistic in any way. I'm incredibly grateful for the guideline efforts, and especially for them emphasizing the areas where there are knowledge gaps. I'm also very grateful for moving away from unfeasible vaginal bleeding assessments and moving towards a more relatable, modern, qualitative assessment that really focuses on the impact on health-related quality of life. And I'm very grateful for the many KTE efforts for women with bleeding disorders. So in conclusion, it is time to address structural barriers to care in the management of women with VWD and other bleeding disorders. Multidisciplinary care for these patients is really best-in-class care and should be adopted universally, as it is for men with hemophilia. Aggressive management of iron deficiency anemia is one way to facilitate health equity and to ensure that women have the highest IQ possible and achieve the highest productivity as possible during their most productive years. It's also important to collaborate on KT efforts and to partner with patients and to ensure that it's accessible to a variety of patients to ensure health equity. And everyone deserves high quality care and care that aligns with their preferences and values. And so for those of you who are interested in bleeding disorders research or research pertaining to health equity, there are so many opportunities here, and it's time for us all to collectively address the knowledge and care gaps for women with VWD and other bleeding disorders, to call out structural sexism in medicine and conduct high quality research in this wide open field. So many asterisks is there. As if you have an interest in research, there are so many people to connect with. There's so much work that can be done. So the discourse is changing and good work is being done, but we are nowhere near done. It's time to move forward with research, healthcare, and policy. We should focus on changing the face of leadership and leadership structures relating to not just women, but also individuals in marginalized groups, to root the changes that we make in implementation science and to measure the changes in access and clinical outcomes, and then to partner with patients to facilitate empowerment and enablement. There are a million people that I need to acknowledge in the work that I've presented today. And in particular, I wanted to acknowledge Dr. Molly Warner, who was my very first mentor in hematology and is the reason that I became attracted to hemostasis. So the impact that you can have on a trainee is huge. She impacted my entire career. I'd also very much like to extend my thanks to Dr. Chantal Séguin for this wonderful opportunity to speak with you today. Thank you.
Thank you. Thank you so much, Dr. Sholzberg, for this really fantastic lecture on a topic that we don't hear of very often, and really very impressive. Congratulations on all the work you're doing advancing this field. We do have quite a few questions and many positive comments coming into the chat. Maybe I'll take the first question here. Can you please comment how aggressively you pursue cascade testing of family members? Most VWD is autosomal dominant, so there can be a family history. So how aggressively do you look for that?
Such a great question. So I presume that you're asking specifically about genetic testing of these patients. And so I definitely am very aggressive in evaluation of any family members of a patient with VWD. And as you comment, yes, autosomal dominant or co-dominant, but again, with variable expressivity and penetrance. And so I think it's really important to test family members, as you may pick up some individuals who have not yet fully manifested, either because they're too young or they've just not had sufficient hemostatic challenges over the course of their life. This is particularly true amongst men. And so I absolutely do test family members. And it's funny because I often have female patients in my clinic who talk about the experience of their mothers and then say, oh, but she doesn't need to see you anymore because she's had a hysterectomy, so she's fine now. And I say, no, but with advancing age, there's an increased risk of requiring surgical intervention. And so we need to make sure that, your family member doesn't have excessive bleeding at the time of any surgical procedure. So there are a million reasons to pursue testing in family members. Surrounding the testing of children, this is where it becomes particularly challenging because, of course, it's no small feat to poke a child. And so there I advise patients to monitor their children carefully and closely. I emphasize evaluating for things such as epistaxis and bruising in unexposed sites, so the chest and the back and the abdomen, because of course having bruises on the legs and the arms in toddlers and in young children is just a sign of health because they're very active. And so I suggest that they monitor those children closely, unless of course there is a particularly severe bleeding phenotype in the family or a severe form of VWD, then we suggest testing to occur early because those patients may require prophylaxis.
Fantastic. Dr. Seguin, I'll let you ask your question, maybe vive voix if you want.
Sure. Thank you, Dr. Gianetti. As I was writing, thank you so much, Michelle, for a fantastic talk. I really enjoyed it. And congratulations for all the work that has been done on this topic. And I just wanted to know, in fact, it's about autocorrection around pregnant women, and how do you take into account this autocorrection in your everyday clinic, in the sense that in pregnant women, in the sense that how frequent would you test? How would you follow them, and what your decisions will be based on basically a certain level, I guess? Or I just wanted to know concretely, like what you were doing around the this autocorrection that is there.
Yeah, thank you. It's a great question. And of course, there's the other side to the coin that I haven't emphasized today. But for example, Dr. Evan Sadler himself said that VWD is in and of itself in search of a diagnosis. And so there are some patients who are overdiagnosed with VWD who may just have low VWF levels without having a pronounced bleeding phenotype, and just have lower VWF levels because of their blood group O status. So even though the guidelines suggest against considering a patient's blood group when they're evaluating VWF levels, I really focus very strongly on the bleeding history. And I will only pursue repeated testing in patients who really have a positive bleeding phenotype. If they don't have a bleeding phenotype, I will not test them unless a family member has really pronounced bleeding, because then I will want to evaluate them further. So my general approach is that I will test a patient likely minimum twice. I will consider whether or not they're on, for example, estrogen-containing therapies at the time of testing. I will also evaluate for, any other extraneous factors, such as I would avoid testing them, in the midst of a viral infection that's inflammatory, for example, or around the time of a trauma, because again, they would be more likely to autocorrect. And so I will test patients repeatedly, and I consider sort of the entire physiological milieu. Like I'm looking at, was the patient sick? Are they on estrogen? Yes, no. What is the personal history of bleeding? And if it's very mild and the levels come back around high 40s, 50%, and I do it twice and it doesn't dip lower and the bleeding history isn't significant, I discharge them.
Oh, fantastic. We have about 2 minutes left. There's questions about prenatal diagnosis and high-risk pregnancies, and at what age do you test the babies at risk? Could you just answer that in
Sure.
the 2 minutes we have left?
For sure. Great question. Prenatal diagnosis, generally not something that we offer, even not often offered for patients who may be carrying a baby affected by hemophilia. Although there are some exceptions, we have done non-invasive prenatal testing for women who may be carrying a boy with severe hemophilia, given the slight increased risk. It's never slight. It's It's always worrisome when someone has an intracranial hemorrhage, but the increased risk of intracranial hemorrhage at the time of birth. So typically, no, we're not. And that's because the genetic basis of the most common form of VWD type 1 is inadequately understood. And so we don't often offer non-invasive testing to evaluate for VWD, because the most common form is typically mild and generally can be easily managed over the course of someone's lifetime if they present and have access to care. And what about the testing of the baby? So we do immediate postnatal testing, meaning we test the cord blood for VWF levels in babies who are delivering at St. Michael's Hospital to mothers with known VWD. And we expect those levels to be very high, sky high, because the baby's, super stressed at the time of birth. And so if they're not sky high, that suggests that the baby may be affected. And then we have a discussion with the patient through the pediatric hematologist to decide whether or not their baby should be tested. And we advise on which types of bleeding symptoms to watch for. And so at what age do we test the babies that are at risk? So typically those babies are brought to pediatric clinics at around 3 months of age, assuming that they haven't experienced a bleeding event within the first 3 months. I can say, though, in my last in the last 10 years of my practice, I have yet, knock on wood, 1,000,000 times, to have a baby born with VWD have a bleeding event in the neonatal period.
Fantastic. Thank you so much. Once again, a great big thanks for this wonderful lecture. I invite you to look at the chat, because there's really, really great comments coming in the chat. I think a lot of your colleagues would have liked to have seen you in person and are congratulating you. Really a pleasure to have you here today. Thank you, Dr. Seguin, for organizing this. And thank you for joining us, everyone, today. Once again, congratulations. And thanks really again for this wonderful lecture.
My pleasure.
Have a great day, everyone.
Thank you.
Bye-bye.